Okay, so now we want to look at pharmacodynamics. Remember, we talked about pharmacodynamics is really medication changes. So how do the mechanism of action of a drug or the effects of the drug, how are they working? What are we expecting to happen? And as a nurse, we really want to know the mechanism of action. We should know the mechanism of action of any drug that we give a patient. And I'm always amazed in clinicals how many of my students don't know what the mechanism of action is of the drug they're about to give a patient. Because we are giving a medication, that's our intervention, then you're always going to want to reassess the patient. So you have to know what you expect to happen with the patient, and that's what you're going to assess. We know what we anticipate that medication is going to do for the patient. So that's all really looking at the pharmacodynamics of medications. Okay, let's look at an example of pharmacodynamics. Nitrostat. A lot of patients have this medication when they have angina or pain in their chest, and that's caused from lack of oxygen to the heart tissue, and it causes pain. Anytime you have lack of oxygen to tissues, it causes pain. So we know with nitrostat, it's going to dilate the coronary vessels, and that's going to allow more, and we oftentimes put on oxygen at the same time. We want to optimize the oxygenated blood to the heart tissues, and that's what causes the angina to diminish or be eliminated. So it improves oxygen supply to the myocardium. That would be the pharmacodynamics of nitrostat or nitroglycerin. Okay, let's look at a few terms that are important for nurses taking care of patients. We're the one administering the drugs, so we really want to understand these terms so we can plan our assessments and interventions. So peak plasma concentration is really amount of time. It's also written as Tmax. How long will I anticipate that a medication will reach its peak level and have the peak response in the patient? It's going to affect how frequently I do my interventions or my reassessments after I give a medication. Therapeutic index is really the difference between the lethal dose and effective dose. Some medications have a very narrow therapeutic index, so it doesn't take much for the patient to get toxic or get subtherapeutic. Lithium is something that has a very narrow therapeutic index, so we have to monitor their blood values and see what their concentration of the medication is to know if they're above or below that very narrow window when the drug works. Duration of action is how long we anticipate the medication to work. We anticipate it's going to work for 12 hours, then we know that the dosing doesn't have to be any more frequent than 12 hours, but that it's going to, that's what, like if we give, say Motrin or ibuprofen every 4 to 6 hours, that's what its duration of action is. Naproxen, 12 hours. So it's a longer duration of action. Things like loading dose and maintenance dose. Loading dose is really a large initial dose of a medication. We want to get that blood concentration up quickly, so you give a higher first dose, and then you give a maintenance dose. So it's going to equal out. The rate of administration is equal to elimination, and you really are able to keep a steady concentration of medication in the body. Sometimes we'll draw peak and trough levels of blood so we can see what the volume of the medication is after a loading dose, and maintenance doses are given to make sure that we're keeping the effective dose of the medication in the patient. Other terms, potency and efficacy. An example, a drug can be more potent because a lower amount causes an effect. Say you give 10 milligrams of drug A, 20 milligrams of drug B, and they both drop down the systolic blood pressure by 20 millimeters of mercury. Well, drug A took less amount to bring it down, so it's more potent. Efficacy is really the magnitude of the maximal response. For example, ibuprofen, you give 200 milligrams is its standard dose. Aspirin, you give 650 milligrams. but you expect the same response or magnitude of response from both of those doses, even though they're different, 200 milligrams and 650. The efficacy is expected from those medications is the same at those doses. Okay, some labs I think you should always be aware of as they affect our absorption, distribution, elimination of medications, mechanism of action. First one being serum albumin, normal 3.5 to 5.5. I would know your textbook what its value is, but this is what the normal range is. So we talked about if somebody has a low serum albumin, they may not have the same ability to bind the medication to bind on the proteins and go to the target tissues, and they could have more free drug. Peak and trough, I talked about that a little bit in the previous material. Peak to a specific drug is the highest expected level, and the trough is the lowest level. So oftentimes we'll draw out a trough right before we give a medication like vancomycin, and then you'll get the peak it will be in the order, you'll get another blood volume and measure the peak of the blood maybe a half hour after administration. The hematocrit and hemoglobin is going to affect perfusion, is going to affect the mechanism of action of the drugs. And men and women are a little bit different. Men have a bit higher hematocrit, 40 to 54, and the hemoglobin 13.5 to 17.5, and women just a bit lower. So always know what your textbook is, but have it really understand what the normal range is. Liver enzymes, remember we talked about the cytochrome 450, and there's over 50 enzymes in that system. We measure things like ALT, AST, liver enzymes, and certain medications can make liver enzymes go up. It's affecting the liver function, and they may not be as good of metabolizers. The other thing, gastric pH. Our stomach is very acidic. 1.5 to 3.5 is the normal acidity in our stomach, and that's going to be taken into account with medications that are taken by mouth. So if they have problems that change the acidity, or a lot of the medications that people take for reflux, proton pump inhibitors, Maalox, the antacids, could affect the acidity of the stomach and then affect the absorption of medications. BUN and creatinine, normal 7 to 20 for the BUN, 0.5 to 1.1 for creatinine. The higher those levels go up, that means the body is not eliminating those components, so the kidney function is altered in those patients. So the higher those numbers go, the less kidney function or less efficient kidney function that patient has. And we talked about older people, you usually see the BUN and creatinine go up, or if they have effects, the kidneys could have nephrotoxic effects and it hurts the kidneys, and you see those numbers rising. And we worry about that because the drug is going to stay in their bloodstream longer and not be eliminated. Creatinine clearance is really a measure of creatinine is eliminated from the body at a constant rate. So if the norm, and we get a 24-hour urine, right? And we're measuring the creatinine clearance, and that is really looking at the glomerular filtration rate, or the urine output. What is the normal elimination pattern of that patient? And we want it between 88 and 137 on average milliliters per minute is how fast the body is eliminating creatinine. But that's really looking at the glomerular filtration rate in the body. As we get older, it slows down. As we have kidney disease, it slows down. So something that we really want to look at, because you can have increased toxic effects because the medications aren't eliminated.